who anyone could think might bear the challenge of chemotherapy in this early disease setting, when ADT alone could be so successful. And so that's why we really saw this high volume, low volume emerge from Charted, because it was really emphasized that it was only the high volume patients who would need to be treated. Next slide, please. What we saw was that if we looked at the all-comers population, in the Charted trial at least, there was a 40% reduction in the risk of mortality associated with that intensification strategy of ADT plus 6 cycles of docetaxel chemotherapy versus ADT alone. And this was even substantiated at the longer-term follow-up, which is what's presented here. And so this patient population seemed to benefit despite the trauma of docetaxel chemotherapy for 6 cycles at the beginning. Next slide, please. What's important and interesting to recognize, I think, is that in the Charted trial, at least, this benefit was really most felt by the patients with high volume disease, as we can see in this survival curve, where those patients treated with the docetaxel ADT combination in the green line had a clear advantage to those patients receiving ADT alone in the blue line. Next slide, please. Importantly, even after longer term follow-up on the low volume patients, there was not a clear benefit to that intensification strategy. This was true really only in Charted, only in patients where we saw a majority of patients actually coming in after having recurrence, after their primary prostate was treated. There were some de novo patients in here too, but most of those were going to be in the high volume setting. So this really raised a conundrum in our community, but still we were thinking, okay, at least for the high volume patients, we can improve overall survival with this combination intensification strategy. Next slide, please. Well, what we saw was that the Stampede study, which also included patients with metastatic hormone-sensitive disease, really helped to add both clarity, but also in some setting or some senses, some confusion to this study. So Stampede, as you can see here, has multiple treatment intensification arms going on, B, C, D, E, F, on down the line. And arm A is an ongoing standard of care arm with ADT, which you see may have had radiation therapy added on later. Next slide, please. But in Stampede, patients with metastatic hormone-sensitive prostate cancer were randomized to receive ADT alone versus ADT plus docetaxel, this standard of care plus docetaxel arm in red. And clearly we see the separation of curves here with an improvement in overall survival, not quite as extreme as with the Charted study, but we do see this improvement with the intensification strategy. Next slide, please. Similarly, there was a 10-month improvement. So Stampede did not stratify by high volume, low volume, and actually just found that there was an overall benefit. And we'll get to their breakdown later in terms of high volume, low volume, which was actually a retrospective analysis. But this is not where treatment intensification stopped. Generally, at this point in time, back in 2017 or so, we recognized that there was a benefit for patients who could tolerate chemotherapy. But what about treatment intensification in patients who may not be able to tolerate that additional chemo? Abiraterone acetate, which we know from this schema and from others that we're aware of, is a medication that stops steroid synthesis. So it stops the adrenal glands from making testosterone, as well as stopping certainly the prostate cancer cells themselves from making testosterone. And next slide, we can see that by inhibiting the enzymes, and we'll just stay here, Mary Kate, that's fine. By inhibiting the enzyme CYP17, we actually decrease testosterone production, but we also can increase mineralocorticoid excess because of low levels of perceived cortisol by the system. And so we always have to give abiraterone with prednisone in order to make sure that we counteract that and have sufficient cortisol in the system to not cause that mineralocorticoid excess. Abiraterone is generally very well tolerated and was tested in the Latitude trial, and we see the New England Journal of Medicine manuscript title here, looking at patients who had high-risk prostate cancer, a little different than high volume, high-risk prostate cancer, metastatic hormone-sensitive disease, to see whether the intensification strategy of ADT plus abiraterone would be as effective as ADT alone. Next slide, please. And in the Latitude trial, we can see here, this is the schema. They were randomized 1-to-1 to ADT plus abiraterone versus ADT plus placebo. Next slide, please. They were defined as being, oh, go back one slide, please. defined as being high risk as having 2 out of 3 of the following. So a Gleason score of greater than or equal to 8, at least 3 bone lesions or bone metastases, or the presence of measurable visceral disease. So they had to have 2 out of 3 of those, and only these high-risk patients could be enrolled. They were followed for a primary endpoint of overall survival and radiographic progression-free survival. Next slide, please. And what we can see from the Latitude trial is that these curves also beautifully separated. In this high-risk population, there was a survival advantage to the intensification of ADT plus Abiraterone versus ADT alone. Nearly, again, a 40% reduction in mortality associated with this combination. Next slide, please. And this was substantiated in that Stampede study. Again, many arms, many assessments being done. Next slide, please. But one of those assessments was ADT alone versus ADT plus Abiraterone. And what we can see is that the blue arm representing patients who had ADT plus Abiraterone had a superior survival as compared to those patients who had ADT alone. And the hazard ratio here also demonstrates a nearly 40% reduction in mortality. This was not only high-risk patients. And so when we as a community of oncologists, medical oncologists, urologists, and radiation oncologists look at this data, we really interpret this to say any patient with metastatic hormone-sensitive disease may benefit rather than looking at that Latitude data, which is only the high-risk patients. Next slide, please. Importantly, at ESMO, there was an update, which is so exciting. With a median follow-up of 6 years, when we look at those patients who were receiving ADT plus Abiraterone, this benefit of the intensification strategy was very clearly still evident in terms of survival and failure-free survival all the way out at that 6-year time point and longer. And importantly, 125 patients on the Abiraterone ADT arm were still on treatment. So that's about 20 to 25% of patients who were on that intensification strategy still on combination therapy at 6 years. So important for us, so important for our patients that this combination could be highly successful even that far out. Next slide, please. Enzalutamide, I think we all know, is actually an androgen receptor antagonist, works in so many ways. Really interesting that actually stops the alteration of the androgen receptor after it's stimulated by its agonist, stops the translocation of that mutated receptor, or that altered receptor, activated receptor, I should say, into the nucleus, and then stops that that translation of the androgen response element. So multiple areas where it can stop the activity of androgen in the setting of prostate cancer. Next slide, please. Enzalutamide was studied in the Enzamet trial, which also looked at this intensification strategy. Next slide, please. In this study, or in this trial, patients with metastatic hormone-sensitive disease were randomized to treatment with ADT plus enzalutamide versus ADT plus nilutamide, flutamide, or bicalutamide. These are very weak androgen receptor antagonists that have been really only used in the setting of testosterone flare in recent days, although have in the past been very useful and important in the care of men with prostate cancer. But what's important here is that ADT plus enzalutamide was randomized against a highly potent, very active control arm that's not just ADT alone, but is really ADT plus something else. So any benefit that we saw, we knew would be against a highly active control. Importantly, also, patients in this trial, like the Titan trial and others that we'll see down the line, actually were able to get docetaxel as well as their regular ADT plus intensified therapy, or their ADT alone. This addition or availability of docetaxel was important because Charted and Stampede had already shown that this was of benefit to patients. So patients were allowed to get this in addition to their ADT plus whatever else they were getting in the Enzamet trial. Next slide, please. And here we can see the overall survival curve demonstrating that enzalutamide plus ADT did have benefit over ADT plus nilutamide, flutamide, or bicalutamide. Very clear separation of curves, about a 33% reduction in mortality. And so really importantly, this led to enzalutamide also being an option in the metastatic hormone-sensitive setting. Next slide, please. What's important, though, is that when we break this down in terms of docetaxel exposure, this chemo that we know from Charted and Stampede can be beneficial, we saw that there was a clinical progression-free survival advantage in the top left to the receipt of ADT plus docetaxel plus enzalutamide versus ADT, docetaxel, and nilutamide, flutamide, or bicalutamide. But when we look at the overall survival curve in the upper right, there is no added benefit to the addition of enzalutamide versus that alternate AR antagonist when patients are getting docetaxel. When we look at the bottom two panels, there's a very clear separation because these are patients who have not received docetaxel. And what this led us as a community to say is that the triple therapy, ADT, docetaxel plus androgen receptor antagonist, enzalutamide, that therapy is not necessary. We need to pick one therapy plus ADT and use that, not the triple therapy, because the overall survival at least does not seem to be improved with that triple approach. I would say that the overall survival curve here for the triple therapy is probably immature at the time of reporting, so we do need to continue to follow that out, and we will also see other studies that help us to understand this. Next slide, please. Also importantly, the side effect profile was worse. In terms of docetaxel side effects, particularly in the triple combination, as opposed to patients who did not receive docetaxel, and even in that the patients who had enzalutamide versus that other non-steroidal anti-androgen. So if we look in particular, things like neuropathy and nail discoloration, as well as watery eyes and fatigue, seem worse in patients who had enzalutamide plus their docetaxel versus docetaxel plus that other non-steroidal. Next slide, please. So the bottom line is we don't use a triple therapy. Titan looked at apalutamide and metastatic hormone-sensitive disease. Let's go to the next slide. And found that when we were able to enroll patients, next slide, and we'll just stick here, with metastatic hormone-sensitive disease, we could randomize them to receive ADT plus apalutamide versus ADT plus placebo, and these patients up to 10% did receive docetaxel as well. Follow them for radiographic progression-free survival or death. We saw that the radiographic progression-free survival in this curve was significantly longer with patients receiving ADT plus apalutamide versus ADT plus placebo. Going to the next slide, please. Here we see overall survival, again, significantly improved with that intensification of ADT plus apalutamide versus ADT plus placebo. So another option demonstrating intensification is much better than ADT alone. Next slide, please. And these are the adverse events. We didn't see anything that kind of stuck out at us, and other than saying that serious adverse events were relatively rare and they were typically related to hormonal type effects. Next slide, please. The health-related quality of life by patient report was also maintained, even though patients had to take an extra pill in addition to their ADT during the duration of the trial. Next slide, please. So I guess one of the main questions, next slide please, is really whether docetaxel is better than an androgen receptor targeted approach when we're thinking about intensification. And there's no perfect answer to this question, but the Stampede trial that, as you saw, had multiple arms moving forward in addition to the ADT alone standard of care arm, was able to help us answer this question a little bit. So Stampede included arms that of course had abiraterone acetate and also had docetaxel. And there was a simultaneous recruitment of patients to ADT plus docetaxel and ADT plus abiraterone arms between 2011 and 2013. And about 566 patients were randomized to these different arms without the intent of being able to compare them. But because this was a simultaneous or contemporaneous randomization, we essentially could compare them as sort of a post hoc unplanned analysis. Next slide, please. What we can see, I think, is really telling on the next slide. We can get there. Sorry for the technical issues. Go back 1 or 2 slides, please. One more. Oh, there, stay. Oh, just one more. There we go. So we can see that these survival curves completely overlap. So standard of care ADT plus docetaxel versus ADT plus abiraterone prednisone, the orangey red versus the blue lines are completely overlapping. The hazard ratio here is 1.16, the p-value is 0.4. So treatment with ADT plus docetaxel versus treatment with ADT plus abiraterone did not show a clear advantage to either arm, meaning that each is potentially a relevant and respectable option. Next slide, please. What we could see is what we expected, that failure-free survival by PSA, progression-free survival, which includes PSA, was favoring Abiraterone because, of course, it's an androgen receptor-directed therapy that is going to lower PSA by its mechanism. But things like overall survival, which is really, I think, at the end of the day, the most important thing, was not different between groups. Next slide, please. So I was fortunate to participate in a quality of life analysis. This is actually hopefully under review right now, but the Stampede contemporaneous randomization also allowed us to look at the quality of life between the two arms receiving these two different therapies. And our group was able to look and model how quality of life seemed between these arms. Docetaxel, as we saw in the charted study, did seem to have this decrease in quality of life during the treatment, as well as, interestingly, in the Stampede trial, over time, even at 18 and 24 months, lower quality of life than the Abiraterone arm. But ultimately, these patients with docetaxel or treated with docetaxel did improve. You can see that rebound there in that red line. Abiraterone had a gradual decline over time, but no real drop the way that we saw with docetaxel. Really importantly, when we looked at this sort of as an average quality of life over time, there was a difference by about 3.9 points that was improved in the Abiraterone group versus the docetaxel group. Now, the question is, of course, what does this mean? Is 4 points really meaningful to patients? I think that is still up for debate, but there was definitely a difference, and we can see a difference here, whether that's meaningful to patients or not, whether that's worth the copay of Abiraterone versus lack of copay in docetaxel, I think is really something that needs to be decided by an individual patient. And there are lots of other factors that they can use to decide, but this quality of life difference did exist within this data set at least. Next slide, please. So does docetaxel really only work in high volume disease? Next slide, please. This was raised by that charted study, initially sort of breaking into high volume, metastatic hormone-sensitive disease, really to get patients to enroll in the trial when there was such a stigma against chemotherapy. And in the charted study, or in the Stampede study, the team was able to go back and look at scans and decide whether or not these patients had high volume or low volume, and look at their response rates by that high and low volume burden. Next slide, please. Next slide, please. Just in the interest of time, we'll look at the curves. What we can see here is that both curves for low burden or low volume and high burden, high volume do seem to separate. Interestingly, in the Stampede data, which included all de novo metastatic hormone-sensitive prostate cancer, for the most part, only about 5% of patients had a treatment of their primary before enrollment. There was a clear separation. So I think as a field, after we saw this data versus the charted data, we've decided or interpreted this to say that all patients with de novo metastatic hormone-sensitive prostate cancer may benefit. Though, of course, I think in the US, we still have a bias and think that it is mostly patients who have high volume, especially de novo metastatic hormone-sensitive disease, who might benefit from docetaxel as our intensification strategy. Next slide, please. Next slide, please. Radiation to the primary is really something that has been in debate. This was also assessed in the Stampede trial. Next slide, please. In this study, patients who had metastatic hormone-sensitive disease were randomized to receive ADT with or without docetaxel versus ADT with or without docetaxel plus radiation to the primary prostate. This schedule of radiation was not necessarily what we would see here in the United States. So it was once weekly fractions versus 55 gray over 4 weeks. So this is not exactly what we would necessarily see, but is something that seemed to be potentially effective. Next slide. And is something that we can continue to discuss, I think, as a field. What we saw in this randomization was that patients did not seem to have, in the all-comers population, a clear advantage to radiating the primary prostate in the setting of metastatic hormone-sensitive disease. Next slide, please. But based on data from the HORAD trial, which looked at high volume and low volume radiation, metastatic hormone-sensitive patients and radiation to those two different populations, the Stampede investigators, prior to the actual analysis of their data and prior to release of their data, did look at the survival advantage to radiation of the prostate in terms of different patient populations, the low volume metastatic population versus the high volume metastatic population. This was defined per the charted criteria, with high volume being 4 or more bone metastases, with at least one being outside of the axial skeleton or visceral disease. That was the high volume population, and low volume was really anything other than that. And what we can see in these two separated survival curves is that patients with high volume metastatic hormone-sensitive disease did not seem to benefit from radiation of the primary. But if we look at the low volume patients, there was a very clear separation of those curves and a survival advantage. You can see the 3-year overall survival with the standard of care, no radiation to the primary, being 73%, and 3-year overall survival for patients who had radiation to the prostate being 81%. So a really pretty big separation and a hazard ratio here of 0.68. So I think for many of us, when we see low volume metastatic hormone-sensitive disease, we will recommend consideration of radiation to the primary prostate in addition to whatever systemic therapy intensification strategy we want to use. Next slide, please. So ongoing studies are continuing to evaluate this. This is the PEACE 1 study, which has, as you can see here, 4 arms that are looking at whether we should be using triple systemic therapy, whether we should be using radiation to the prostate. This study that is actually, at this point in time, I think enrollment is complete, and we expect and hope for these results to be present and available for us to review, hopefully next year. Next slide, please. There's a SWOG study that is really looking at treatment of the primary tumor, whether it's with radiation or with surgery, SWOG 1802. Again, metastatic hormone-sensitive patients. This is including as well really best systemic therapy for patients who and randomizing them if they are not progressing on best systemic therapy to treatment of that primary prostate or not. So we will have more data from this as well. Next slide, please. And the ARASENS trial, which includes patients with metastatic hormone-sensitive prostate cancer who receive ADT plus docetaxel with or without darolutamide, is also hopefully going to be reporting out, hopefully at the end of this year, to see whether, again, this triple therapy approach may be better than double therapy. This would be ADT plus docetaxel in the control arm. So a very, very strong control arm. Next slide, please. So let's talk for a minute about, or a few minutes about genetic testing. Next slide, please. Genetic testing really has become a standard of care for men with metastatic prostate cancer. Mutations that we know can affect these patients could be either germline or somatic, but we have to test for them in order to really find them. Germline mutations are expected in approximately 11.8% of patients who have metastatic disease. And as we continue to sort of enhance that population by continuing therapies over time, the castration-resistant population may have even more and more of these germline alterations. But because the threshold of 10% of the population having a germline genetic alteration was met in the metastatic disease setting, all patients with metastatic disease are actually recommended to undergo germline testing. So I think this can be complicated to think about. We at Northwestern are really fortunate to have a phenomenal genetic counselor who helps us with certainly responding to alterations that are of significance and even variants of unknown significance, VUSs, in our patient population. But for some practices, I think this can be really daunting because germline genetic testing can have implications for families that really need to be dealt with and addressed, and certainly patients and their families may need counseling. Importantly, as we as a field move towards doing germline genetic testing for all metastatic patients, we will be able to, I think, rely on and draw on chatbots that are associated with genetic testing platforms and companies, as well as hopefully things like telehealth to allow our patients or empower our patients to have the counseling that they need if they do have a positive test. This is all very much still in flux, but just to be very clear, the NCCN guidelines do suggest every patient with metastatic prostate cancer undergo germline genetic testing. Again, this can be blood, saliva, even a cheek swab, but this is something that is recommended. Somatic DNA testing can also be done on tumor tissue, but I would caution everyone who's doing that to really, if they do see a DNA repair defect alteration in that somatic tissue testing, to reflex and ensure that they're doing germline testing as well. For example, if you're doing tumor tissue testing and you find a BRCA2 mutation, if it's not clear that this is a germline mutation, and actually even if it is, you should reflex to germline confirmatory testing or germline exploratory testing to see if that BRCA2 is germline or somatic, so that you can figure it out. Because families who may have inherited this could certainly be at higher risk in women of having ovarian or breast cancer, and other cancers as well, and certainly men for having a higher risk of prostate cancer. Pancreatic cancer and some urothelial cancers are also higher risk, and certainly they would benefit from a genetic counselor. 23% of metastatic castration-resistant prostate cancers do also have DNA repair alterations, so something that we can actually at this point in time act on, as there are several PARP inhibitors that are now approved for patients with metastatic CRPC. One of those, the landmark trial, was actually led by our own Maha Hussein at Northwestern, who has actually contributed, as everyone on this webinar knows, I think, to many therapies for advanced prostate cancer, but this is one of the latest and most important ones as well. And as I said, 11.8% of patients with metastatic disease are going to have these alterations. As you can see on the right, these alterations are predominantly BRCA2, but there are multiple other alterations that we can see, including ATM, CHEK2, BRCA1, and PALB2 is another that I would bring your attention to. PALB2 can be super sensitive to these PARP inhibitors, similar to BRCA2, which again is the most common and also seems to be the most sensitive to PARP inhibitors in prostate cancer. Next slide, please. Although we may not recognize it, I do want to emphasize, and my genetic counselor friend, Brittany Simonak, has also emphasized this with me, that family history still must be considered. We do have to counsel our patients and talk to our patients, because sometimes patients who come in with prostate cancer have a family history that includes diseases that are outside of the standard BRCA1, BRCA2 familial cancer syndrome risk, that may require a broader panel of genetic testing for germline testing. And so these are the patients that we might want to send upfront to genetic counselors rather than doing the germline genetic testing on our own. And if you have access to a genetic counselor, of course, that is a great resource and a place where you can send patients. If you do not, then this might be a patient to engage with a chatbot, through a genetic testing company even before you get the results back. And if possible, if you're collecting family history, if you're doing this on your own, as my counselor suggests, 3 to 4 generations are ideal. Any prior genetic testing that has been done in the family can be useful and illustrative to help kind of target what needs to be investigated. And really, as I said, this helps you understand if you need the sort of more narrow prostate cancer germline genetic testing series of alterations to be assessed, or if you need to go more broad for a different familial cancer syndrome that isn't necessarily in our typical wheelhouse for men with prostate cancer. And I think having access to a genetic counselor, or certainly contacting colleagues who can help with this, is going to be really important as we as a field continue to evolve in our understanding of genetic testing. Next slide, please. In addition, tissue testing must be done, not necessarily for the hormone-sensitive setting, but certainly for patients who have disease that progresses past hormone-sensitive metastatic disease. Importantly, as we're doing this testing, we are looking for DNA repair alterations like BRCA1, BRCA2, PALB2, CHEK2, all of the things that I mentioned earlier. But also we're looking for tumor mutational burden greater than 10, MSI high status, and these MSH, MLH mutation statuses, which can also make the patient eligible for pembrolizumab. This is going to be about 3% of our population when we get into the metastatic castration-resistant setting, but if we can identify them even when they have metastatic hormone-sensitive disease, we can be right there to get them on pembrolizumab if that's the right treatment when they have progression of disease and need to go on to something else. pembrolizumab can be extremely effective. And I have had the good fortune of having a couple of patients treated with this and respond to this. And it's pretty phenomenal and unbelievable, but something that if we don't test for it, we're not going to be able to find it, and we won't be able to help our patients. Next slide, please. This slide just illustrates that really it's about 2 to 3% of our patient population that is going to have this MSH or MSI high status or these alterations, tumor mutational burden greater than 10 again. And what the CT scans on the right show is just this dramatic reduction in disease burden with these checkpoint inhibitors, particularly pembrolizumab, which is the only one that's actually approved for this setting. Next slide, please. So as we wrap up and are eagerly looking forward to questions, these are my summary points. Earlier androgen receptor-directed therapy or chemotherapy as intensification strategies can prolong overall survival in metastatic hormone-sensitive disease. So please don't treat patients with ADT alone unless they have extreme comorbidities or you do not think that they will have a life expectancy long enough, longer than a year or so, to be able to benefit from these treatment strategies. Because these intensification strategies can improve both survival and quality of life in our patients. And these are the two things that we aim for and strive for more than anything else. Certainly, metastatic hormone-sensitive disease has become incredibly crowded, and we continue to learn more and more. But as we're trying to sort of pick through the options, I would say fit patients with de novo metastatic disease can consider docetaxel as a good option. Of course, being mindful of the pandemic and being mindful of the immunosuppression or myelosuppression that comes with this. Abiraterone, Apalutamide, and Enzalutamide are all options in metastatic hormone-sensitive disease, whether it's low volume, whether it's high volume, high risk, low risk, especially if these patients are unfit for chemo, these are options for us. Radiation to the primary tumor prolongs overall survival in low volume metastatic hormone-sensitive disease. And there are studies that are ongoing that are really trying to understand if surgery may be a good option in this setting as well, and really trying to sort through the nuances. But this is something that I talk to all of my patients about with low volume metastatic disease. It may not be the treatment option that everyone wants to take, but I do think is worth mentioning to patients with low volume metastatic disease. And germline genetic testing is recommended for all men with metastatic prostate cancer. Somatic testing should also be considered initially or on progression, that we can send tissue testing or sometimes liquid biopsies to try to identify additional areas for treatment for those patients with metastatic hormone-sensitive prostate cancer that has now progressed on to metastatic castration-resistant prostate cancer. And even though it is rare, make sure you're looking for MSI high status, tumor mutational burden status, and the germline alterations that can put patients at risk for having this sensitivity to pembrolizumab, because it can be a really powerful therapy as we move into the metastatic castration-resistant disease setting. So thank you all for being so patient. Thank you, Mary Kate, for advancing all of those slides. And I apologize for having a Mac. But I would love to take questions and really have a conversation. We've got a lot of great clinicians on this call, and so I'm happy to engage all of them as we try to answer some questions.
Hi, Alicia. It's Ted Schaefer. Awesome overview. Thank you so much. I want to be a little bit controversial, and I want to ask you, I'm a patient and I read the literature, and you say that 23% of men with metastatic prostate cancer have a mutation in a mismatch repair protein. And I would say, well, I read the paper, and only 40% of men who had BRCA1, BRCA2, or ATM had a response to olaparib. And most patients in the other arm had no response. So, what are your thoughts about that? Because I feel like perhaps it's being overstated or overestimated as to the potential benefit of germline genetic testing and or somatic testing of my tumor, in this particular disease state.
Thank you so much, Dr. Schaefer. As an esteemed member of the NCCN, I feel like you may have had debates around this issue as those guidelines were being prepared. So I sincerely appreciate you bringing that debate to this conversation. And would love to hear your thoughts on it as well. I think from a patient perspective, this is a completely reasonable argument or question to ask. Not everyone who has these alterations will respond to a PARP inhibitor. There is no question about that. And I think what this calls for is for us as a field to continue to really refine our ability to predict response in what we think is already a biomarker selected population. I know you and your team are really working on this, and I sincerely look forward to the validation of some of the signatures that you and the team are defining that may be more of a BRCA-ness population, or a population that may be sensitive to inhibition with PARP inhibitors, that's more accurate than just saying, well, you have a BRCA2 mutation, or you have an ATM mutation, which again does not actually seem to be so responsive. I also think it's important and interesting for us to recognize that the PARP inhibitors may actually have effects in patients who don't have these alterations when combined with androgen receptor directed therapies, as we saw a few years ago in a phase 2 out of the UK, where patients who were given Abiraterone and Olaparib, even if they didn't have DNA repair alterations, had a better response to therapy than patients who received Abiraterone alone. This story is absolutely still unfolding, and so I think requires a lot more investigation. I would say, though, that from a family perspective, the reason that we suggest germline testing for these patients is because if you find an alteration that is considered to be pathologic, particularly in BRCA1 and BRCA2, that information can be really powerful for families. And it is not uncommon, I've talked to many colleagues about this, that they have found patients who have a BRCA1 or BRCA2, family members, young daughters in many cases, get tested, also have BRCA1, BRCA2, have a mammogram and have an early stage breast cancer, or don't, but are at such high risk of having a breast or ovarian cancer that they undergo prophylactic surgery because those women want to avoid risk in the future. And there are even patients here at Northwestern who have been touched by this and whose families have been, I think family members have been saved because of this. So the germline genetic testing, I think, absolutely has a role. The therapeutic approaches are still being defined. And I do look to you and other colleagues to help us understand, beyond having these DNA repair defects, what are the signatures that are really going to be associated with the response? And which of those patients who does not have a BRCA1, BRCA2, or other DNA repair defect may also benefit from these kinds of PARP inhibitors and combination treatments, because that's where the real information is going to be, and that's how we're going to personalize our treatments beyond just helping to advise families.
Thanks, Dr. Morgans. I think there's a question from Rich in the audience.
Hi, Dr. Morgans. Great talk. It's Rich Motilevich, New York City. I was curious what your thoughts on the new oral anti-androgens are, and whether that's going to preclude the need to use combination therapy in the future.
And Rich, just to follow up to make sure I understand, do you mean the oral GnRH antagonist therapy, or do you mean like the oral enzalutamide, Apalutamide?
Specifically relugolix.
Okay, thank you for clarifying that. So just so the audience is aware, I did not include this information because it's much broader than hormone sensitive, but there was a recently approved GnRH antagonist oral agent called relugolix. And this medication essentially is used in a similar setting to leuprolide, gaserelin, triptorelin, the other pharmacologic ways that we lower testosterone. But those agents that I just mentioned are GnRH agonists. So these are injectable mutations that cause the pituitary to stop stimulating the testes to make testosterone, but they do it in kind of a roundabout way, whereas the antagonist that Rich just mentioned does it in a little bit more direct way, still going through the pituitary to get to the testicles, but a little more direct than the alternate approach. Interestingly and importantly, the GnRH antagonists, like this oral agent, seem to have a lower risk of cardiovascular complications as compared to the agonists, those other agents that I mentioned, gaserelin, leuprolide, triptorelin. And when we look at all of these agents as a big group of androgen deprivation therapies, because that's what they are, these agents are the backbone for treatment for anybody with advanced prostate cancer that's metastatic or high risk localized or even biochemically recurrent, PSA rising. So in the context of that whole preamble, sorry everybody, I just wanted to make sure we were on the same page. To answer Rich's question, I do think that these GnRH antagonists like relugolix do have an absolute role, and I'm excited to see where this role kind of plants itself. I am most excited for those agents because they have about half of the cardiovascular risks of at least one of the GnRH agonists, leuprolide, meaning that the risk of cardiovascular complications in the first year after treatment seems to be lower with these GnRH agonist approaches. And for patients with prostate cancer, we know that 90% or more of these men actually have cardiovascular comorbidities that will put them at high risk to have a cardiac event at some point in their life. If we can lower that risk, we're taking care of the whole patient. That's always important to us, I'm sure. The other thing that's nice about these agents is that when you stop them, and they're an oral agent, so you can stop them as a patient more effectively than if you're a patient who's getting an injection, which really relies on your doctor to help you get it or not get it. You can actually stop them and then the testosterone recovers more quickly. And in some settings, I think this can be really, really important and helpful, particularly when you're using intermittent androgen deprivation therapy, and potentially even when you're getting combination androgen deprivation therapy with radiation, and you have a defined period of exposure, low testosterone that you want, and you want to have quick recovery on the back end. I think there are still questions that are out there, like, if you have that fast recovery associated with your radiation treatment, does that compromise your cure rate? Do you need to extend your exposure longer than the previously defined period in order to ensure that you have the same disease control that you would have if you had one of the injectables? And I think that all remains to be seen. But I do think, Rich, that from my perspective, this new oral agent, relugolix, is coming into the scene, will be helpful for a lot of men, particularly men who have recognized cardiovascular risk. I don't think it's going to negate the need for intensification, because that's really only replacing the leuprolide, gaserelin, triptorelin, that ADT backbone, that thing that was the standard of care. We still need to go standard of care plus in order to get that intensification strategy to have both improvement in overall survival and improvement in quality of life as well. So this is really just a replacement for the backbone, but does not replace the intensification approach from my perspective. Thank you for the question.
Thank you.
I thought I saw a question from Dr. Sosman too. Are you still on, Dr. Sosman?
Yeah, I'm on. I won't ask a question about kidney cancer, I promise.
Thank you, Jeff.
So about the germline and somatic mutations, is there any clinical characteristics of patients with prostate cancer that suggest that they're most likely or more likely to have an alteration in one of these repair genes outside of a family history?
Thank you, Jeff. I love this question because I think in some solid tumors, the answer is yes. But I think in prostate cancer, one of the most important findings from the early studies looking at this in metastatic prostate cancer is that neither young age nor family history was sufficiently associated with finding these DNA repair defect alterations that those should be considered in our testing strategy. And to put that into plainer English, regardless of the age of the patient, regardless of the patient's family history, the patient with metastatic prostate cancer should undergo germline genetic testing, because the risk is high enough that that individual will have one of these alterations, that we should be assessing them, and we will hopefully, if it's there, find that alteration and be able to act on it. So certainly in family histories, when you see the family tree completely riddled, unfortunately, with different malignancies over time, and they fit into our little, criteria for breast or ovarian cancer syndromes, we think of BRCA1, BRCA2 as being key players, and in many cases they are. but that is not a strong enough driver among metastatic prostate cancer patients that we really use it to direct our germline genetic testing. Did that answer the question, Jeff, or what? I just want to make sure.
Yeah, no, that was perfect. This may really expose my ignorance on this, but a patient who has BRCA2 somatic mutation versus a patient who has germline, which obviously has it in the tumor, is there a difference in sensitivity to PARP inhibitors?
So no ignorance exposed. Another great question, Jeff. So I think that we don't have enough data to really answer that question, but there does not seem to be a huge difference at this point from the exploratory analyses that we have access to. I would say, though, that many of the patients who have these BRCA2 alterations, for example, have double hits. They are, for many of them, a majority of them, they are homozygous, germline and somatic. They are going to have 2 hits. So it's interesting that that's not the case with all of our patients, but most of our patients, BRCA2 at least, do have germline abnormalities. But I think we're still trying to figure it out. The numbers remain small. And we do look forward to further release of exploratory data from the PROfound study that Maha was involved in and others to really understand that better.
Thank you.
Thank you, Jeff.
Wonderful. Well, thanks again. That was a phenomenal talk. I think, as everyone knows, we recorded this, and I think we'll try to get it online for people that want to listen to it again or let friends know that they can access it. Thank you again, Dr. Morgans. It was terrific. I hope everyone has a nice evening and joins us in a couple of weeks for our next session.
Thank you so much for the invitation. Have a good evening, everyone.
Thank you.